we're going to cover 4 topics today. We're going to cover the historical context of Olmstead, the Supreme Court's Olmstead decision itself, litigation about Olmstead, and initial policy approaches to Olmstead. Thank you. Next slide, please. So first we're going to talk about the historical context. And next slide. So historian Paul Longmore described a clash of 2 contradictory public policies. The first were exclusionary and segregationist policies that were supported by conservatives and progressives alike. And the second trend are toward democratic and integrationist policies that are based in civil rights and self-determination that were fought for and won by people with disabilities themselves. Next slide, please. Historically, the treatment of people with disabilities has been a sort of long trial, starting with unsightly beggar ordinances that barred people with disabilities from appearing in public. The first of these that's known was in San Francisco in 1867. Forced commitment to almshouses, poor farms, or hospitals, later to large-scale institutions. This was intended to spare society from, quote, unsightly and unseemly people. The relegation to segregated education to avoid hindering the education of non-disabled children. That was the express intent, and that was upheld by the Wisconsin Supreme Court in 1918. Next slide, please. They've been subject to job discrimination, including explicit federal and civil service and New Deal work relief provisions, which rejected people with disabilities as unemployable. People with disabilities were used as part of the labor force during the labor shortages of World War II. I've missed turning this slide. Ellen, oh, I guess we're okay, sorry. But then they lost jobs when the war ended. Subject to forced sterilization, particularly of those with developmental disabilities, and were the focus of euthanasia policies advocated by leading social activists. And finally, policies that exist to this day that keep millions of working-age adults out of the job market by means of social welfare policies that provide health insurance, personal assistance services, and payment for assistive devices as long as they stay unemployed and impoverished. Next slide, please. So, in the face of that history, disability rights movements emerged as a force for change. There were many movements operating from of many different constituencies, but they were operating from similar principles. They rose around the common fight against warehousing people in institutions, and so we can see that that thread of what Olmstead is all about is deep in the movement. And during this period of time, we saw the founding of the independent living movement. Next slide, please. Some key elements arose out of this agenda of disability rights movements. And some of these were legal protection from discrimination, the right to receive quality treatment or services, the right to refuse such treatment or services, due process in all professional or governmental decision-making about them, equal access to public transportation and accommodations, and again, most fundamental, opposition to forced institutionalization and correspondingly, the right to services in the community. Next slide, please. So there have been many success stories in the battle for disability rights, and I'm going to talk about 3 landmark achievements. And the first being the 1975 Individuals with Disabilities Education Act, which was passed by Congress, when children with disabilities gained the right to go to public school and get an education alongside non-disabled peers, ending an era where at least 1 million children were denied education altogether and 4 million more were segregated from mainstream schools. Next slide, please. Of course, in 1990, the Americans with Disabilities Act, known to all of us as the ADA, was passed as the world's first comprehensive prohibition of discrimination on the basis of disability. It was interestingly passed by overwhelming bipartisan majorities in Congress after 2 years of extensive hearings. These hearings detailed the staggering isolation that was faced by people with disabilities prior to the passage of the ADA. It was signed into law by President George H.W. Bush on July 26, 1990. Next slide, please. And then finally, the subject of our training today, what we're going to consider in more detail, on June 22nd, 1999, in response to a lawsuit filed by 2 Georgia women residing in a state psychiatric hospital, the U.S. Supreme Court ruled in Olmstead v. LC, that's the sort of legal name for the case, that unnecessary segregation and institutionalization of persons with disabilities is a type of discrimination that violates Title II of the ADA. Next slide, please. So now we're going to look at the Supreme Court's Olmstead decision, what it said and what it meant. Next slide, please. In the ruling, the court wrote, if you would please mute your phone with a *6, thank you. The court wrote, confinement in an institution severely diminishes the everyday life activities of individuals, including family relations, social contacts, work options, economic independence, educational advancement, and cultural enrichment. The next slide, please. The court explained that unnecessary institutionalization perpetuates unwarranted assumptions that people with disabilities are incapable or unworthy of participating in community life. Next slide, please. In interpreting the ADA, the court relied heavily on an implementation regulation that had been promulgated by the U.S. Department of Justice. This is referred to as the integration mandate. The ADA's integration mandate requires state and local governments to administer services, programs, and activities in the most integrated setting appropriate to the needs of qualified individuals with disabilities. Next slide, please. Importantly, federal courts have consistently ruled that the Olmstead decision's protections apply to people living in the community, not just those who are already institutionalized. And this is going to be a key factor that is not well understood and that can be very important to explain in advocacy. Next slide, please. A second important feature of the ADA that the court relied on in the Olmstead decision is the requirement for state or local government to make reasonable modifications in policies, practices, or procedures when the modifications are necessary to avoid discrimination on the basis of disability. Next slide, please. A clause that's very important in the Supreme Court's Olmstead decision was called the Fundamental Alteration Clause. And it allowed that state and local governments are excused from making a modification if it would, quote, fundamentally alter the nature of the service, program, or activity. So this is very important, and what does or doesn't constitute a fundamental alteration is rather critical. I think it's important to note that courts have ruled that a state's claim of inadequate financial resources is not just automatically considered a fundamental alteration. So the argument that implementing the ADA in Olmstead is going to cost states money is not a fundamental alteration. Next slide, please. The Olmstead ruling required that states must develop a working plan to serve qualified individuals in the least restrictive, most integrated setting. And the court also required that states must maintain a waiting list that moves persons to less restrictive settings at a reasonable pace that is not controlled by the state's efforts to keep its institutions fully populated. Next slide, please. In 2000, the U.S. Department of Health and Human Services issued guidelines to states for complying with the Olmstead decision, and it included 4 key things that states needed to do to comply. One was to incorporate consumer input into the state plan, to prevent further unjustified institutionalization. So there had to actually be a plan in place to ensure that new people weren't being inappropriately institutionalized. Ensure ongoing availability of services for people with disabilities to live in the community, and to ensure quality improvement and sound management to implement the plan. It's kind of remarkable to go back, and I was aware of those, but it's interesting to go back and look at them through the lens of all that we've been through the last few years, and look at that requirement in the original Olmstead decision to ensure the ongoing availability of services for people with disabilities to live in the community. Again, I think that's not well understood by policymakers. Next slide, please. Okay, so what's happened in 12 years in California since the Olmstead decision? These are a few of the things that have happened. The original California Olmstead plan lacked specificity and accountability. There's a lack of a system in the long-term care system that results in fragmentation of services and funding, with impacts on individual consumers as well as overall budgets for services. Policymakers have acknowledged the effectiveness of the in-home supportive services program and other home and community-based services in reducing dependence on nursing home services, yet there have been decisions made to reduce the funding for IHSS and other home and community-based services. Next slide, please. State policies and practices impede moving people out of institutions, including a dearth of nursing home facility waiver slots, MSSP and other alternative programs, a limit on the home upkeep allowance, which makes it unusable. There's been progress towards deinstitutionalization in the Department of Developmental Disabilities and the Department of Rehabilitation, with far less progress in other departments. Next slide, please. There have been small, federally funded pilot programs, but there's been limited expansion and deployment of those programs. Huge increases in spending for nursing homes, whose funding is separate from home and community-based services. A lack of legislative knowledge and leadership on Olmstead and community integration as compared to legislative mandates in other states. Next slide, please. And finally, sort of to round up the top 10 things that have happened with Olmstead in California, we have duplicative use of assessments for long-term care users and lack of a true care management for those who want it. And a very important aspect of this is the lack of affordable, accessible housing as a major barrier to community integration, with no coordinated effort to overcome this barrier. So those are a lot of barriers. And that's sort of the environment in which we're now advocating for the Olmstead implementation to be taken seriously. Moving on to the next slide. This sort of brings us up to the fact that Olmstead hasn't been taken seriously in many states up till now, and that has resulted in a lot of litigation contesting the fact that it hasn't been seriously implemented across the nation. So, next slide, please. There's been a big sea change in that direction since President Obama took office. He's made a major priority of implementing Olmstead and put a lot of focus and resources behind making that happen. Under the leadership of Assistant Attorney General Tom Perez, the U.S. Department of Justice Civil Rights Division announced that it is again open for business and has identified Olmstead enforcement as one of its absolute top priorities. The DOJ is now involved in litigation on Olmstead in over 20 states and is adding new cases almost every time you check their website. Next slide, please. So this litigation that is springing up every day is setting a lot of precedents in terms of Olmstead policy. I'm going to go through some of the national cases that are setting precedents, and then I'm going to outline some of the lawsuits that have occurred here in California. So, as I said, DOJ action is creating an unprecedented and rapidly expanding body of Olmstead policy. By and large, policymakers are not aware of this body of law and are not yet incorporating it into planning and decision making. And there's a significant opportunity to use education and advocacy to align policy with these precedents. Next slide, please. So these are highlights of several significant cases that resonate when you take a look at our recent public policy debates in California. Some of these cases are being set that are addressing the very issues that we're struggling with. NIP v. Purdue in Georgia was a recent historic settlement that will, they have announced at the DOJ, it will serve as a template for Olmstead enforcement across the country. It sets the standard for transitioning people with developmental and mental health disabilities to the community. It requires the state of Georgia to create an array of community services for 9,000 individuals with mental illness, and it provides at least 1,000 Medicaid waivers to transition all individuals with developmental disabilities from state hospitals to community settings. Next slide, please. Boyd v. Herman Steckel in Alabama and Lee v. Dudek in Florida are both cases that focus on people with physical disabilities who were forced into nursing homes because of a lack of community services. The DOJ Acting Section Chief Renee Wallenhouse notes that, quote, virtually all individuals in nursing homes in many places could be served in the community. Next slide, please. Another significant case is Disability Advocates, Inc. v. David A. Patterson from New York. This is on appeal to the Second Circuit right now. This is a precedent-setting case that requires moving people with mental health disabilities out of large adult homes and into community-based settings. This is a significant case because it sort of speaks to the idea of an institutional setting. I think the argument has been made that these large adult homes were the community. And so this case directly tested that question of these sort of large institution-like settings, and the conclusion is that those are not community settings and that states must truly integrate people, not put them into interim facilities, that places that look and feel like facilities. Next slide, please. Okay, another case that speaks directly to some of our recent public policy debates in California was Hildebrand v. Levy in Missouri. A preliminary injunction was granted in this case, preventing the state from restricting medically necessary incontinence supplies to people with disabilities living in communities while providing them to nursing home residents. Wallenhouse comments about this case that the DOJ is not just going to work on large items that people need to live in the community, but on their small needs too, because sometimes those things are critical for people to be able to live in the community. And if they're available in an institutional setting and they're necessary, they should also be provided in the community. Next slide, please. So Frederick v. the Department of Public Welfare of the Commonwealth of Pennsylvania is a case that dealt with the inadequacy of the state's Olmstead plan to address the 4 items I mentioned before were set down by the U.S. Department of Health and Human Services: time frame or target date, approximate number of persons to be discharged, eligibility standards for home and community-based services, and a general description of interagency collaboration. Woolman House notes about this case that many of the state plans do not meet these required elements, and that the DOJ is currently offering technical assistance to states to help them understand and do what they need to do to comply. She stated, "We are working night and day to get this initiative working effectively." Next slide, please. So turning to DOJ activity in California, it was very interesting to be on a White House conference call recently. Maybe some of you also were on that call. This was about the Georgia settlement, but it was in October, and on that call, Assistant Attorney General Perez mentioned California specifically, saying you can't use your budget crisis to shirk your responsibilities. Next slide, please. So, courtesy of a memo from Disability Rights California, which I'm going to take you in a minute to our website where you can find some handouts and training materials, and there'll be a full description of these cases if you want them. I'm just going to go through and hit some of the high points of the significant California Olmstead cases. So, first in Chambers versus the City and County of San Francisco, this was settlement of a class action lawsuit against San Francisco on behalf of residents of Laguna Honda Hospital. San Francisco agreed to create 500 affordable, accessible housing subsidiaries, also provide case management, mental health, and other services for class members who are moving or diverted out of placement of Laguna Honda Hospital as a result of this lawsuit. Another significant California Olmstead case was Capital People First versus the Department of Developmental Services. Settlement of this class action lawsuit against the state and 21 regional centers on behalf of Californians with developmental disabilities who are residing in or at risk of placement in state-run private institutions, both state-run and private institutions. Settlement in this case resulted in protection of funding for community placements from state-run developmental centers, as well as increased case management for people in developmental centers and enhanced assessments and information for people in private institutions. Next slide, please. Coda v. David Maxwell Jolly was a class action lawsuit against the Department of Healthcare Services that challenged the cutbacks to Medi-Cal-funded adult day healthcare services. The first preliminary injunction was issued in September of 2009, preventing across-the-board cuts to Medi-Cal funding from up to 5 days to a maximum of 3 days of attendance, regardless of need. VL versus Wagner was a class action lawsuit against both the Departments of Social Services and Healthcare Services. This challenged the significant cuts to the in-home supportive services program based on the use of functional ranks and functional index scores. The cuts, if they had been implemented, would have reduced or terminated IHSS services to 130,000 Californians with disabilities. On the next slide. Finally, a recent case, Napper versus the County of Sacramento. This is a class action lawsuit filed against the County of Sacramento challenging the county's decision to terminate provider contracts serving 5,000 mental health clients and bring all services in-house without adequate transition planning to make that change. A preliminary injunction was issued in this case on July 21st, 2010, stopping the county from implementing its proposed plan until the court determines that clients will continue to receive integrated services to avoid institutionalization. The interesting precedent being set in this case, there are several, but one that I note particularly is emergency room and being sent to a psychiatric facility like the Sacramento mental health treatment center were defined as institutionalization. And so that question had been a little bit up in the air prior to this case, and I think now it's been pretty clear that the court is extending the protections of Olmstead to people with mental health disabilities who are institutionalized in those kinds of emergency room and psychiatric hospital settings on a short-term basis. Okay, next slide. So in all of these cases, the Department of Justice has explained that they have a new framework for Olmstead enforcement that's very significant. The question that they're asking is, does the person belong in an institutional setting in the first place? And that's instead of the previous approach of just trying to fix institutional abuses. And so that's like one of the foundations of this new Department of Justice Olmstead enforcement. They also understand very clearly that these kinds of changes require resources, and they're working closely with the Centers for Medicare and Medicaid Services, with Housing and Urban Development Department, and Health and Human Services in order to bring federal resources and policies into alignment with the goals of Olmstead. Next slide, please. The DOJ is also coordinating with the U.S. Health and Human Services Department Office of Civil Rights. So they are currently investigating another 30 Olmstead complaints on top of the 20 cases that the DOJ has filed amicus briefs in, as well as conducting several statewide compliance reviews. So the DOJ said we're just coordinating really closely with those efforts so that they're all moving us in the right direction. Next slide, please. So finally, in a word to advocates, to fully understand the impacts of the developing Olmstead litigation, Acting Section Chief Willenhouse recommends that advocates create working relationships with their local United States Attorney's Office. So that takes us through the first couple of sections here of the training. And so I wanted to pause now and take a few questions before we move on to questions of public policy about this section of the training. So I'm going to lean on Alan here to help us. First, before we ask for people to raise their hands, go ahead. Go ahead, Alan.
There's one question in the chat, and if people will raise their hands if they have a question. Lisa Cooley has asked how to avoid program duplication, considering the fact that California has 58 counties.
One of my favorite questions. Thank you, Lisa. We're going to get into that question a little bit later on, but let me say right now that the question of what is the state role and what is the county role in systems design is absolutely essential. And it's not well coordinated now, and it has not had, I think there's general agreement that there's been a real lack of planning and coordination in our system. In fact, most people agree that it's not a system at all. So one of the things we're going to talk about in the second half of this training is the opportunities for creating a system. And I would argue that really carefully thinking out what is the state role and what is the county role so that those things complement each other and they end up with good results for the person is absolutely essential and just where we need to go. Okay.
Okay, and if there are any other questions, please raise your hand. If you're using a screen reader, you can type in /hand up to raise your hand. Otherwise, just click the little raise your hand button below names.
So, Lauren Steinberg has a question, Alan.
Have one. Right. So, Laurel, if you can close your microphone, and Laurel Steinberg, you can open your mic and ask your question.
Whoops, looks like she's having some technical difficulties. She's dialing back in.
Yeah.
In the meantime, Lisa Cooley had a follow-up question that I can't answer, so I'll just announce her question. How often are compliance reviews performed? I don't know the answer to that, Lisa, but we'll make a note of that, and we will get back to you with that. Okay, Lauren Steinberg.
I was wondering what the difference is between complaints and litigation with the Department of Justice and with the Department of Health and Human Services.
That is an excellent question, an area that we probably need to go into further. I can give you a little bit of an example in that the investigations of the California state hospitals, state psychiatric hospitals, I think occurred under the auspices of the Office of Civil Rights. And so I'm not sure what their historical difference has been, but the clear message from DOJ is they're bringing those things together so that they're all working from the same page. And the most important impact that they noted of that collaboration is that the manpower working on Olmstead enforcement is sort of doubled from that. So I'm not certain in the past that they had carefully thought out what their different roles were, but now they're sort of all working from the same songbook was really what they wanted to communicate to us.
Okay.
I see a question that's been typed from
There's
Doug.
also a question.
Okay, sorry, Alan. I think we're on the same page. Doug Chandler has asked, can you talk about the liability of an ILC if a person has been assisted in leaving an institution and this is unsuccessful? So I'm not an attorney. I probably should have said that before I reviewed the litigation, and I don't know. I really can't answer that question. I think there are probably people on this call who can, but I think that we're going to table that as a specific question. As far as I know, this hasn't been a large issue, but it sounds like you have knowledge, Doug. Are you able to speak to us? Are you, Doug? I'm going to turn off my microphone and let Doug try and elaborate a little bit on this question. So he's going to call in. Let's leave that and come back to that question at the end of the training, Doug, and we might even have some of the people who are more experienced in that area be able to help fill us in. So I'm going to table your question while you call in, and Alan might help you with the call-in number. So I'm not seeing other hands raised or other questions in the chat. So I think I'm going to go ahead and move into the next section. And Alan's helping Doug, I see there. So Alan, if you would move to the next slide. Great. We're going to move into some discussion about Olmstead public policy. Okay, next slide, please. So this is my favorite quote about policy that comes from a book called Implementation. And it was all about the complexities of implementation and designing programs that actually make a difference and have an impact on people. And you can see it there. It says, hopes and prayers, the general desire to do good without knowing how, seem to us frail reeds on which to lean, though these are the bases on which many programs are begun. So we're gonna talk about some strategies for influencing, making public policy that actually has a chance of success. Next slide, please. So this area is vast, and there isn't time to cover all of the really important critical Olmstead public policy issues, but we're going to talk about 3. And also embedded in this discussion, I'm going to refer you to a couple of our upcoming trainings that are going to tackle some of these critical issues in depth. So we're going to talk just a little bit about strategies for utilizing policy analysis, refining cost-effectiveness arguments, and focusing on so-called long-term care reform strategies as initial approaches to implementing Olmstead. Next slide, please. There is a terrific little slim book that has been very, very helpful to me, and you might find this worthwhile picking up, by Eugene Bardock, called Steps in Policy Analysis. And I'm just going to describe the steps, but at the end of this I'm going to let you know about a handout that gives a little bit more detail about these steps and how to conduct them. It's really important whenever you're starting to consider any policy questions to clearly understand and define the problem. What is it that we're trying to fix here? And that's just an excellent question to always ask whenever you're trying to make public policy. Research, assembling some evidence is so critical. Later in this presentation, we're going to try and cover some best practices from other states. That's one kind of evidence. There are other kinds of data and evidence, but it's pretty important to back up policy arguments with evidence. Describing potential options or interventions is a critical step. And Bardock suggests always including the do-nothing alternative and analyzing it. And this is because, you know, without the bill or the initiative or the regulation, nothing is going to happen. And sometimes it's very important and powerful to demonstrate what the results of doing nothing are. So he encourages people to always include that in your analysis. And then selecting the criteria that will define success, including cost effectiveness, but not limited to cost effectiveness, is important before you ever start. So what will a successful program or intervention look like at the end of the day? Next slide, please. The next step in policy analysis is to project the outcomes of each alternative, including consideration of unintended consequences, which is probably one of the most important things that responsible policy analysis can do. It's important to, after having gone through all these steps, to confront the trade-offs. Sometimes this is called a cost-benefit analysis, and it brings in non-fiscal considerations like the public good to be considered, as well as the law and other factors. Having laid all of that out, the next step is to decide on the best option and then communicate your analysis in simple terms. So A Practical Guide to Policy Analysis is the name of the book, and as I say, in a minute or two I'm going to do something fancy here and take you to our website and show you where you can find that as a handout for this training, sort of a short synopsis of those steps. Next slide, please. So sometimes we as advocates do not have access to all of the data to do our own analysis. In making arguments, though, it's really a great strategy to conduct as many of the steps as possible because they result in better solutions to propose as well as more defensible arguments. We should also look for all of those steps, those policy analysis steps, in all of the legislation, policy proposals, and ideas that are proposed at stakeholder processes. The people who put forth proposals have a responsibility to analyze, articulate, and defend the rationale and the evidence for their proposals. I can't tell you how many times I've been invited to a stakeholder meeting where basically all of those steps were skipped until choose between alternatives. And so sometimes it was very clear that no one had ever tried to figure out what the actual problem was we were trying to fix. They were just sort of throwing solutions at the problem and asking stakeholders to choose between them without that logical analysis behind it. So sometimes a good strategy is to ask questions about the analysis and the reasons behind the proposals, and that sort of makes people be kind of systematic about why they're proposing things and what the trade-offs, etc. are. Next slide, please. Sound policy analysis that takes into consideration the law, the public good, successful outcomes, cost effectiveness, and similar considerations tends to lead to policies that support Olmstead implementation. So one of the most successful strategies is really to get policymakers to do a full and responsible analysis of those issues, and perhaps to suggest some areas that they haven't considered in conducting their analysis and their policy choices. Next slide, please. So another strategy I want to suggest to people is to move beyond what I call it's cheaper advocacy. It's extremely frustrating that government moves so slowly, often does not do the right thing, even when it costs less. It's a source of constant frustration and aggravation. But the ubiquitous claim of advocates all the time that it's cheaper in all Olmstead conversations has limitations that can backfire, and it has the tendency to undermine success. So I want to suggest that refining our advocacy tools will result in better outcomes. And we're going to talk about some ways to do that. Next slide, please. So one of the reasons it's cheaper advocacy has limitations is that really it's bigger than that. Paul Longmore wrote that a key principle is the claim that people with disabilities have a right to the means necessary for them to participate in the community. And this principle redefines services, assistive devices, accessibility, reasonable accommodations, not as ways for caring for those who are fundamentally dependent, but as alternative modes of functioning and the necessary means for social participation and integration. Next slide. I'm not sure why I'm getting that message, Alan, but disability rights advocates have also campaigned for the establishment of these means as enforceable rights rather than dispensations of public or private charity. That's an important distinction. Next slide, please. Finally, Paul writes that advocates have sometimes argued that funding community-based living and in-home supportive services is less expensive than institutionalization or nursing home placement. But more important than that pragmatic argument, they have asserted not only the right of people with disabilities to live in the world, but also their right to make that means effective. Next slide, please. So sometimes the argument is bigger than it's cheaper, and sometimes it's more specific. And one of the times that it's more specific is when you're talking to budget analysts. This useful slide, which I really enjoy, came from Dr. Hendrickson, whose work I will, Dr. Les Hendrickson, whose work I will talk about in a minute. He shared this insight from being a longtime administrator of state Medicaid programs. He says, budget analysts are always working on the budget, and there is never a good time to talk to them. If you wish to talk with a budget analyst, do not use words. They do fiscal impacts. Talking about your good program just wastes time. And these are some unspoken rules that you might encounter. The answer is always no. If they're given estimates by program before they begin work, add 10% to the cost and cut their savings estimate by 10%. That's before you ever even start. And finally, operate by the unwritten rule that nothing is cost effective. So I put that in here so that we can think about how to make some of these arguments effective even when you're working in that environment of speaking to budget analysts. Next slide, please. So if we're going to refine advocacy strategies, one way to refine it is to think about the populations that we're talking about. So beginning with people living in institutions now, those folks are covered by the ADA and Olmstead. So it's the law that they should have the option to live in the community. In the case of people that are living in institutions now, it's also demonstrably more cost-effective, even through the lens of budget analysts. There are also better outcomes, so more public good, serving them in the community, as well as it's compliant with the Olmstead decision. So all of those things come together in a really strong way in the case of the population of people living in institutions already. And so in this case, this population, the key factor is political will to make the change. Moving next to people with disabilities who are living in the community now. So some of the issues that come up in speaking to this population, they're covered by the Americans with Disabilities Act as well. And just lest policymakers don't get this refinement or this point, this key point, as I said before, federal courts have ruled consistently that the Olmstead decision's protections apply to people living in the community, not just to those already institutionalized, so they are also covered by Olmstead. And I think that people within our community understand that, and I'm not so sure that it's well understood outside. However, there's interpretation and somewhat of debate about who is at imminent risk of institutionalization. We saw that this year in the budget hearings around the budget at the state capitol. That phrase, who is at imminent risk, was really being tested in those policy arenas. I have to say, since I've been watching Olmstead, I think that it's a step forward that people are debating who's at imminent risk, but I think taken as a whole, that really doesn't necessarily reflect the Olmstead totality. But nevertheless, we work in a political environment, and those are arguments that are part of the political environment. So there are concerns about the woodwork effect, and that is that if you provide a service, people will come out of the woodwork. Many of us find that phrase very offensive, but it's come to reflect the idea that there will be a high demand for services, so there will be more costs. So arguments based on cost effectiveness may not bear out. Next slide, please. So I think one of the things we want to do here is not just let it be only a fiscal analysis, because fiscal analysis does not address unmet need, poor health outcomes, social isolation, homelessness, poverty, prolonged suffering, or the inability to live a life as intended under the Americans with Disabilities Act. Moving beyond its cheaper advocacy brings those larger concerns into the policy arena as legitimate considerations. Next slide, please. Another consideration in being really focused about using cost-effectiveness arguments is who's saving the money. When you're talking to policymakers, it's also critical to keep in mind who will save the money from spending the money, and making sure that you're talking to the right people about the savings that will accrue. State policymakers struggling with a budget deficit may be less concerned about costs to hospitals, emergency rooms, or local governments. And the reverse is true for counties who may have increased costs from providing in-home supportive services, but by and large have no fiscal worries if a person enters a nursing home where the state pays for costs. I say in general or by and large there because institutions for mental disease are a different case, but the point here being that whoever you're talking to about savings needs to be the recipient of the savings if you want that argument to be effective with them. Next slide, please. Fiscal analysis is also notoriously grounded in a 12-month time frame. In the next 12 months, it may not be cheaper to provide services because the impacts of not meeting people's needs may be borne mostly by the individual until poor outcomes accumulate into fiscal impacts, and that might be next year or the year after for government. Next slide, please. So the strategy here is to for advocates always to extend the vision beyond the current budget as an essential consideration in making these decisions. It's also important to use tools to explain the cost effectiveness of prevention, and there's a whole set of strategies that people who work in prevention use for starting to explain how little things equal big things with big costs over time. And so starting to master and utilize those kind of arguments can be very important and effective. I use an example here that mental health advocates have successfully made the argument in the passage of Prop 63 that the human and fiscal costs of the fail-first model to access services is far too costly for both the person and the system, and that argument was one of the key components in getting Prop 63 passed. Next slide, please. So, the point of this section is that its cheaper arguments need to be used really strategically and with precision, and that they should not upstage the larger agenda of meaningful disability rights in public policy advocacy. Sometimes they can really be on target, and other times, we really want to start speaking of the larger picture. Also wanted to let you know that our July 21st, 2011 training with Dr. Stephen Kay will provide more detailed information about the supposed woodwork effect, how to understand the true cost effectiveness of home and community-based services, and making cost effectiveness arguments to policies that work. Steve has a new model for estimating costs. He's really excited about it, and so we're going to be focusing on that in July. Okay, so if we move to the next slide. So the sort of final third of the topics we're going to cover in public policy is about so-called long-term care reform. So I acknowledge here that long-term care is just not a beloved word in our community. One advocate has described it as sounding like a life sentence. It's historically referred to nursing home care and other institutional care. It is being replaced with long-term services and supports. Some people have argued that that's not much better, but that's intended to reflect the inclusion of home and community-based services in long-term services and supports. Next slide, please. However advocates feel about the semantics, I would argue that we need to become experts in the financing and organization of the long-term care system. If somebody could please do *6, we can hear you talking. Thank you. It's complicated, it's thankless, frustrating. It often seems far removed from the needs of the person, but that area called long-term care reform is sort of the nut that must be cracked for Olmstead to succeed, because it deals with the financing and the delivery of services. So I recommend that a good place to start is to make the Malika-Hendrickson report your dog-eared constant companion and bedtime reading. Next slide, please. So we've posted this report under training materials. I'm going to take you there in a second. But this is the name of the report, Home and Community-Based Long-Term Care, Recommendations for Improving Access for Californians. It's a project of the California Community Choices. I call them the California Community Choices Project, so I got that in there twice. But Robert Malika and Leslie Hendrickson, two national experts, have worked on this report with a lot of input from advocates in our community. I want to especially note Deborah Doctor's influence in helping to shape this, along with many others. And it's a wonderful survey of the complexity of California's long-term care system, and it really takes us in the direction that we need to go to make a system-wide implementation of Olmstead. Next slide, please. I want to share with you some resources for understanding long-term care issues. I'm going to take you to our website and show you where you can find a video clip of Dr. Hendrickson's testimony. It's sort of short, but you can see the orientation of that we're starting to move into on the basis of this report. I want to share a PowerPoint presentation by Dr. Hendrickson on long-term reform strategies. So this is his summary and synopsis of that long 300-page report in a very accessible PowerPoint presentation that pulls out the most salient, important issues and where to start. And I want to mention that on June 23rd, our training on the game-changing strategy is going to cover long-term care reform issues and opportunities for change through the implementation of healthcare reform. So right now, I'm going to just show you, if you'll bear with me, I'm going to show you our website. Okay, gosh, it's like magic. I'm so easily pleased. You can expand the window as it comes up for you. But just briefly, I just wanted to show you our website. I think most of you already came here to register for our training series, but this video clip of Dr. Hendrickson speaking to the Senate Aging and Long-Term Care Committee is right here. And in this clip, he's answering the question of what California should do in a time of no money. I think people were a little surprised about the answers, so I encourage you to come back. I can't show it to you without dropping people off the call, so I'm going to encourage you to come back on your own and take a look at that. But I'm also going here to, on the left navigation bar where it says training materials, and I'm going to show you all of the handouts, as well as the presentations themselves from this training series, are going to be posted here on our website under training materials. You can see the name of the training, and there's the BARDOC policy analysis summary, sort of a short and handy summary. There's also the Disability Rights California summary of California Olmstead litigation. The third document there you can see is Dr. Hendrickson's PowerPoint presentation, which is a sort of accessible bite out of that large report, help you sort of get your hands on it. And finally, the report itself, which I think there's really no substitute for reading it. Probably I've had to read it a few times before I'm starting to really get the full picture, but it's complex because our system is complex, and it really brings together what we need to do to start to create a meaningful system. While we're here, I'm going to just take you briefly over also to, on your left navigation bar, you can see California Olmstead Summit. And I'm going to take you there for a second. And if you scroll down, there's a lot of documents here that were posted, and some of them I've drawn from for this presentation. From a summit that was held in September, we had, for example, the Assistant Attorney General Sam Bagenstos from the Department of Justice come and speak to us, and his keynote address is there. You'll find a wealth of resources here, including Mathis, New York handout. It's Jennifer Mathis from the Bazelon Center giving us some very important resources. So I just refer you here to our website, where we're going to continue to build our training resources. So that should bring us back, if all the magic is working, into our PowerPoint presentation. And Alan, if you turn to the next slide. Good. So now I talked in the beginning about assembling some evidence. So we've tried to work on understanding California's long-term care system and explaining and painting the picture of what a better system, a meaningful system, would look like. And so this is just a little bit of a taste. You can find more in that page I just showed you, resources, but I want to just introduce these ideas. These are some best practices, as I said, to inform the development of our long-term care system. And what we've considered here are characteristics of effective state long-term care systems. Washington, Oregon, and Vermont are known for having effective long-term care systems that serve people well. And then to address Lisa's question, I want to talk just for a minute about what an effective county long-term care system, because we are not Oregon, Washington, or Vermont, certainly not Vermont. We are a large, complex state with 58 distinct counties, and so it's very important to give consideration to the question of what the state and the county role is so that the person isn't struggling with those system issues and we're getting good outcomes for people. Next slide, please. So the Washington state model is well known, and we had the benefit of meeting with Charlie Reed a couple of times, who was one of the administrators until he retired of the system, and really trying to get our hands on how it works. So they began by defining a strong statement of vision and values that guided the development of their long-term care system. They also have a number of core elements in place in their system, and I'm going to kind of describe them. If you would turn to the next slide, Alan, sorry. So the core elements that inform this effective system are a strong statement of mission and values to guide system development, a single organizational unit in state government to plan, develop, and operate the long-term care system, a single budget with flexibility and authority to spend on a varied and robust array of long-term care services. Next slide, please. A process for assuring quality oversight throughout the system, strong and organized stakeholders and advocates. And I think that's what we're trying to do today, is get strong and organized. A process for resource development that meets consumer demand, and as, for example, as the certain populations grow, there's some contingency for resources to grow to meet that growing population. For example, the gray tsunami of older adults, growing population of older adults and other populations. Fast, timely, and standardized financial and functional eligibility that generates reliable data. A care coordination system with capacity to provide assistance and oversight for consumers, and finally, fair rate setting and contracting processes for providers. Next slide, please. So we took those sort of pillars of understanding what it would take to actually have a system, a systemic approach to providing services. And we looked at those qualities in Washington, Oregon, and Vermont, and we found that by and large, all of those states have all of those elements. And so from that, we're able to start to discern that these are sort of critical pieces that any effective long-term care system is going to need to address. Next slide, please. So as Lisa mentioned, how is it that the state and county work together? And what we know is all too often they don't. However, there's been a great effort in San Francisco. There are other counties such as Sonoma and San Diego who are also trying to develop a functional local system. So this is what they have discovered is helping them. And as I go through this list briefly and mention these things, what you're going to immediately recognize is that some of them are the same characteristics of effective statewide systems. So as we go into healthcare reform and we're designing a long-term care system that's effective, one of the things we're going to look for is these core elements. And then a very important thing that we need to address here in California is how that looks in a county and how those things fit together. So effective county long-term care systems that San Francisco is using or attempting to use are that it be consumer-driven, have a single point of entry, which allows them to have quality assurance, a comprehensive package of services that are tailored to the individual and can change with his or her needs as their needs change. Seamless transitions between care settings. Next slide, please. Also, a package designed on assessment with consumer choice. We're not just designing services based on how much money we have. We're actually assessing people's needs and then creating a budget and resources that fund what they need in real life. Funding for services, a robust array of services, and clear lines of responsibility and oversight, as well as flexibility to make changes. I think flexibility to make changes may have been an element on its own. I may have mislabeled it. Okay, so the next slide. So one of the most powerful things about this thinking, it's a little complex to dig into and to sort of think about these systems questions, but I was really motivated when I had a chance to talk to Charlie Reed about Washington to understand what it is that actually creating a functional system can mean to advocacy and to outcomes. And so I want to paint a picture for people of how budgeting looks when you've got that effective system. And I've been surprised to find that when you describe this to policymakers, they're astonished. In California, at least, that's been my experience several times. As a result of their effective long-term care system, Washington State policymakers have confidence that spending these funds does actually save the state money. And that has been proven and studied over a period of time so that there's actual confidence that spending on home and community-based services is in fact reducing their institutional and nursing home costs. So the debate that we are mired in quite often is actually, they've leapfrogged by that over a period of years by designing this effective system. They have a long-term care forecasting commission. This commission makes an estimate based on assessment data. So, you know, every year they assess all of the people who qualify for services. They project the total need for long-term care services based on those assessments, including all home and community-based services. It's all one budget. And then the governor and the legislature agree without further ado to put that funding recommended by the Forecasting Commission into the budget. So you can see how different that is from what we're doing, which is that every separate home and community-based service is a separate fight in the budget battles to try and protect that, which tends to pit services against each other, etc. And so the power of having an actual system and an array of services, and one of the fundamental aspects of this is having a universal budget. And that's sort of the importance of what I talked about before of becoming experts in long-term care, or the new term long-term service and supports. The reason we see long-term there is that those institutional budgets for nursing homes and other services need to be part of the universal budget so that on an equal basis, people can get what they need and want, and the budget is allocated to cover the costs of that array of services. So it takes us out of the model of having a competition between this growing institutional costs over on one side and funding home and community-based services on the other side, and we have one system. And so the more we spend on home and community-based services, the less we spend on nursing homes, and it's very apparent because of the data and assessment and the process, and it results in this elegant budget-making process which basically gets people what they need without having a food fight every year over which programs to fund. So, next slide please, Alan. I just, as a conclusion, I wanted to say that I had the privilege of being part of the ARC's Public Policy Conference recently, and I listened to wonderful Art Bolton tell the story of how the Lanterman Act was passed in California and how that fantastic system that we have, that works very well, was set up and advocated for and won. And I was really struck by the fact that policy is not made in that way at the legislature anymore, largely because of term limits. In the era of term limits, community-based organizations have become the key engine for policy development. I think it's absolutely critical that we increase our policymaking capacity to meet this challenge and create systems change to implement the Olmstead decision for all people with disabilities in California. And I think that's what all of you have done today, is increase your capacity, and so I'm very grateful that you've all attended. In the next slide, I'll just mention that at the end of the webinar, when you get out of this window, you'll automatically be directed to a brief 5-minute evaluation. If you would please take a minute to fill out the evaluation, give us your feedback so we can make these trainings as effective as possible, we'd be extremely grateful. The next slide gives you our website. I think Alan already put it in the chat box, but it tells you where our website can be found that we looked at. This training will be posted there within a couple of days with reps captions and with the narrative attached. I also want to invite you to join the Californians for Olmstead Coalition at the site. Just on that left navigation bar is a area that says join, and you can join the coalition and you'll get our emails and notices about our monthly teleconference. We also have a Facebook page. Many of you are members already, but I invite you to join. So we've actually, I think, timed this correctly, so we have about 10 minutes left here at the end for questions. And I'm grateful that you listened to me talk for so long, and I'd be very happy to try and answer any questions or put them on the agenda for things we're going to explore over the next few months. Okay, so go ahead.
Laurel, there are some questions in the queue, and you may have answered some of them about independent living centers have the requirement of creating community placement plans. That's a question from Lisa.
Okay, do independent living centers have the requirement of creating community placement plans? I don't fully understand the question, Lisa. I'm not sure if you're talking about the California Community Transitions Program. As far as I know, the federal funding for independent living centers does not require anything so specific as developing a community placement plan, but I think that many ILCs are involved in assisting with that. So I'm not quite sure of the nuance of what you're talking about, whether you're talking specifically about the California Community Transitions Program or the general activities of independent living centers. And I have to just acknowledge I'm not the expert on ILC requirements. Can you talk to us, Lisa? Do you want to elaborate a little bit? I'm going to turn my mic off and give you a chance to. Okay, I'm not hearing Lisa. Maybe she's not hooked up to voice. So we'll make a note of some of these.
Yeah, I'm not sure.
Okay. So we'll make a note of some of these more specific questions, and we'll try to incorporate them in. We also collaborate closely with the Systems Change Network, which are deep into all of these things. We interface with the Transition to Home program that works on the California Community Transitions Program. So we may rely on some of our more experienced colleagues in some of these areas on the details. Shall I just pull out some of these questions in chat, Alan? So,
yeah, and then there's someone, Doug has a question on the telephone.
Great. So, Doug, why don't you go ahead and ask us, and then I'll catch up on the chat box here. Go ahead.
Okay, let me take another stab at what I was asking earlier. What I was wondering is if you facilitate somebody moving out of an institution, and say that institution has a waiting list. They move out into the community, and for one reason or another, they're unsuccessful in being able to successfully live in the community. They can no longer get back into the place where they had been. Does that put any liability on the Independent Living Center for having tried to get them out of that setting? And like you said, you're not an attorney, so I don't know that you're going to have any other answer besides what you had before, but that was the question that I had.
Well, it's a very interesting question that I hadn't thought of, so I'm glad you raised it. I think the Olmstead decision itself it's a systems question. It's a policy and litigation question at this point. So a question of individual liability is not something that I work on, but I'm wondering why you're asking, because it sounds like you may have had an experience where this has come up, and I wasn't aware that this might be a question. Has this arisen in your work?
It has arisen from the perspective of needing to make sure that we look into that question while we move forward on some of the work that we're doing.
Well, I'm going to keep it in mind too.
So I'm not saying we've been sued or anything like that. I'm saying that we need to. We've discussed it and wondered, where we stand on that.
I'm not aware, and it would seem
the part of what you said about having a clear plan, and looking at how you arrange everything, making sure that everything is brought, all of that you arrange everything with a lot of foresight is, a helpful part of that process, obviously.
Yes. I would think it would be a very bad development if ILCs were considered liable for something like that. I really haven't heard of any cases like that, but I really want to connect you to the California Community Transitions Program and the work that they're doing through Transition to Home, where they're dealing with providers of transition services, and who knows, that question may have come up there. So let me refer you to them. Are you plugged in, Doug, to their work?
I don't directly provide work in that area, so I'm just going to refer that to somebody who is.
Okay. Well, I think they're the best resource. I am not aware of any cases like that, but the limits of my knowledge doesn't mean universal truth. Okay. So I want to. You're very welcome. I'm seeing. I may have missed something from Sharon Lynn that looks like it got answered. I will just sort of say briefly, Sharon, your question looks like about addressing transition plans for students exiting the educational system. And I did not directly go into that very deeply except to talk about the goals of the disability rights movement, but I want to mention to you that the Yo Disabled and Proud CFILC Youth Advocacy Project is actually working on that very question right now, especially in helping people in community colleges access disability services and supports. And one of the nice things about working with CFILC is together we are all working on the range of issues just like this. And so, when I'm working on Olmstead policy, someone at Yo is working on the educational system disability services cuts. So Yo Disabled and Proud is a place to go if you want to work on that specific issue. So just Sharon, did you want to elaborate on that question a little bit, or did that answer your basic question? Okay. So Sharon communicated by chat, so I'll just move on to the next question. Patricia Feldman has asked, is there a nursing home lobby against this movement? Such a good question, and I will just say in a word, yes. And all of the people who are part of the long-term care system our stakeholders in how it gets redesigned, and the nursing home lobby no less than others. And I would just say that's why we need to focus on developing our policy expertise as much as possible to be effective on behalf of the person and translate that into systems policy advocacy. So, thank you. Diane Rose. I should let Pat elaborate on that a little bit, so you're not just listening to me. Pat, did you have a comment you wanted to make about the nursing home lobby in Olmstead? Okay, so I'm hoping in the evaluation people will let us know if you're not able to speak up, or make sure that you are able to use all of the tools effectively. I'm just sort of on a black hole here. I'm not sure if people are able to access all the tools. I want to answer a question by Diane Rose, which was, what motivation is there for counties to be involved in long-term planning? You guys have great questions. The purpose of a universal budget is to involve all levels of responsibility, including counties, in this effort. Right now, one might argue that not much. There's not much incentive to do that. There are a whole bunch of complex issues going on sort of separately, and counties have a role in several important pieces of that. But do they feel motivation to make sure that Olmstead gets implemented? I think this is an area of great opportunity for advocacy. One of the things that we're going to be developing here is a short presentation and a toolkit for advocates to take to the various people that they meet with, including their boards of supervisors, local officials, ombudsman programs, district offices of elected officials, and we're going to adapt the first part of this, the first 10 or 15 slides that describe Olmstead, into a very short version of this for people to use to go out and present, because I would just say that there's not a lot of knowledge or expertise about the county responsibility in sharing responsibility for implementing Olmstead. So, and also, in healthcare reform and the various realignment proposals that are going on, there is opportunity for creating incentives for counties to participate. So I think it is just about 3:30, and I'm just scanning quickly. It looks like I may have caught all of the major questions. I want to just...
Laurel, there.
Yeah, go ahead.
Laurel, there are two that you may not have caught. Jennifer Walsh asked if states are mandated to provide community services regardless of financial hardships. How do they go about doing that?
Well, it's I don't think Olmstead addresses how a state organizes itself to make sure that there are financial resources available. I think that the legal decisions speak to the responsibilities of states for ensuring people's civil rights. And the squishiness of the last 12 years, where we haven't seen a lot of progress in Olmstead, reflects the complexity of that question. For myself, when I hear the Department of Justice say you can't use your budget crisis to shirk your responsibilities, I think that's a very strong statement of what the federal government's evolving view of states' responsibilities are. I also look back on the original requirements of the Olmstead decision and the Health and Human Services Department's guidelines, and there are glaring shortcomings in California's compliance with even the first and most basic requirements. And I guess as an advocate, one of my goals is to revisit that information, understand it, and explain it in the policy environment and in my advocacy, so that policymakers start to understand those responsibilities better. And then we are all constantly involved in the efforts to make sure that our state is solvent and meeting its fiscal responsibilities, but that is mostly up to the state. The federal government has set these broad standards of expectations for outcomes. So it's a whole area of it's very complex. Was there another one that I missed, Alan?
The other question was from Lauren and Freed. Imminent risk is an interesting concept. However, when programs like IHSS are underutilized, it is a long-term effect that will ultimately affect institutionalization. How do we argue that point?
Come to the training in July with Steve Kay, and he was going to teach us all about his wonderful new model that basically demonstrates with quantitative evidence exactly the point that you just made, Lauren, that, you know, there's a cost to unmet need. And over time, those costs become apparent. They're costs to the person, and they become costs to the system. And so investing in things that sustain people in the community and prevent them from deteriorating is a good investment for our state, and Steve's going to teach us some really important tools to make that case.
Okay, are there any other questions?
And I see a final question from Nancy Hall that we can answer affirmatively. She's asking if there's a listserv for transition to home, and there certainly is. Ed Ahern from WCIL is a lead organizer in Transition to Home. And Nancy, I will send you his contact information, and anybody else that's interested in Transition to Home can go to their website, which is, I think, www.transitiontohome.org. Is that right, Alan?
Yes.
Terrific. Oh, perfect. Alan's just listed Ed's email address in the chat box. So I guess we are ready to close this session of our training. I hope that many of you will join us for the the 4 upcoming trainings that we'll be considering over the next few months. And I want to thank Teresa Favusi, the Executive Director of CFILC, for making this work possible, and the Department of Rehabilitation for also for making this work possible, and my colleague Alan Friedman and Rhett Simmons, who provided the technical assistance and captioning. And I thank you all very much, and we will sign off for now. Bye.